So we're going to talk about the basic sensing, capturing, a little bit about the procedure and the coding, and then talk a little bit about the indications, why we do it, and then get into the more functional aspects. So this is to show how pacemakers save lives. This was somebody who was cleaning their gun. The can is made of titanium. The bullet got lodged in the can, and it saved their life. So, pacemakers save lives. So, the idea here is that it's going to deliver enough electrical energy to depolarize the heart. It's going to correctly sense the activity that's going on in the heart so it can make some good decisions about which beats need to be provided and which ones don't. Essentially, the pacemaker is responsible for two things. It's to sense electrical activity that's intrinsic to the heart and to provide what's missing. It's a clock. It's set like an alarm clock for a second from now, and if it doesn't see a pace beat, if it doesn't see an intrinsic beat, it provides one, and if it does see one, it'll skip. It's more complicated. Sensing is the ability of the pacemaker to actually see the signal, and it doesn't just look for the size of the signal. It looks for amplitude, slew rate, and frequency. Amplitude is how big the electrical signal is. Slew rate is how rapidly it's changing. So if a signal gets above the energy or the voltage necessary to be detected, but it's rising very slowly, the pacemaker knows the difference between that and something that rises very quickly, which is most likely an electrical signal from the conducting system of the heart. And the frequency, if the signal that it's seeing is occurring very, very rapidly or very, very slowly, it'll know not to treat it as electrical activity from the heart. So it uses all three of these criteria to try to decide if what it's seeing is a heartbeat or not. Capture is the other thing we talk about, which is the ability to deliver energy in a way that reliably causes all the cells of the heart to depolarize and contract. We want to find the right amount of energy. Too little and it won't be reliable, too much and the battery won't last. So it makes some decisions about that. Capture threshold, I think you're all familiar with. It's the minimum amount of energy that'll do the job without wasting battery life. The reasons we put it in, I think all of you are very familiar with this. Symptomatic bradycardia. The guidelines have changed now. Asymptomatic bradycardia is not supposed to be a criteria, although we all have a really hard time with the very frail person who's not used to doing anything, who's laying flat in bed, who's got a heart rate of 19, who says, I feel fine. But if you stand them up, if you tried to get them to do stuff, they probably wouldn't, but they don't do that at home. And technically, we're not supposed to put pacers in those folks. There used to be criteria that allowed you to use particular slow heart rates or particular pause lengths to put pacemakers in, but those were taken away. Any kind of advanced heart block, especially with symptoms, certainly syncope, tachybrady when the heart goes too fast and too slow intermittently, and you need to use medications to keep the heart from going too fast. And that medication would make the slow spells worse. That is an approved indication for pacing. You don't have to prove it by waiting until they get symptoms. For some patients with atrial fibrillation, we're now ablating the AV node, especially if they don't tolerate medications. The rate-slowing medicines drop blood pressure and so forth. It gets very difficult in some folks to give them enough medication to keep the heart from going too fast. And in that case, you can ablate the AV node, but then the ventricles won't know when to fire, so a pacemaker is the way you provide backup. And CRT or bi-V pacing is used for heart failure. Resynchronizes the right and left ventricle. If somebody's got a wide QRS and a low ejection fraction, this is extremely effective. So they come as single chamber devices. One can, one lead, usually goes to the ventricle. And if someone has no effective atrial activity, most commonly permanent AF, then this is what you'll see used. Or there can be two leads, one going to the atrium, one going to the ventricle, still just one can, but two separate circuits, and they talk to each other. And then, although it's beyond the scope of this talk, there's also a 3-lead system. You can run a lead down into the, not into the left ventricle, but there's a vein that goes on the back of the heart from the right ventricle, from the coronary sinus, and there are veins on the back of the left ventricle, and you put a lead in there so that you can pace the left ventricle without having any hardware inside it. Obviously, we wouldn't want to have a lead in the left ventricle because any clots that form would cause strokes. That's not good. The leads we use are endocardial. They come in through the vein, travel down into the, either stop in the atrium or across the tricuspid valve and go into the ventricle. They attach to the endocardium, which conducts much more efficiently than the muscle or the epicardium. In some cases, we do put epicardial wires in. These have to be put in the operating room. The lead goes on the exterior surface of the heart. Can be pretty unreliable. Scar tissue can develop, and the longevity of these leads are poor. The most common reason for that are our patients who have bad social habits, drug users, and repetitively seed their vascular space with bacteria, and leaving endovascular leads in is just going to get recurrently infected. So we put epicardial leads in that population. The newest kind are the leadless pacemakers. They're tiny, they're this big. The entire pacemaker is in here, and it has little tiny tines that help it hold on to the heart. Right now, they only work in the ventricle. They can't sense in the atrium and the ventricle. They're extremely resistant to infection. So these can be used in drug users. The problem is that they're not removable. The current generation are not removable, and they occupy some volume in the right ventricle, and the battery only lasts about 12 to 14 years. So if somebody's in their 20s or their 30s, you'd wind up filling their heart with hardware over the years, and that's no good. The newer generation of these devices will be removable, so that as one wears out, you can pull it out and put a new one in. Right now, based on the currently available technology, we want folks to be elderly, specifically because we can't put more than one in the ventricle. So you put it in someone who has a longevity of less than 12 to 14 years. AF is the most common underlying rhythm because there's no atrial interaction between this pacemaker and the atrium. But even if someone's in sinus rhythm but only is getting paced because they have occasional long pauses, this can go in because it only be used for occasional rhythm support, not anything on a continuous basis. Of the leads that we place, nowadays, this is the only kind we use, but you'll see patients come in with all 3 kinds. There are some leads that have these flexible tines on them. The inner surface of the right ventricle is trabeculated. It's full of little nooks and crannies and grooves. And these things can go into those grooves, but they won't come back out because they're like little barbs, like fish hooks. These have fins. They do the same sort of thing. And on the surface, it's very porous. Many of the leads nowadays have steroids in tiny little pores in these leads, so that where they contact the muscle, there's less inflammation, less chance of scar tissue forming, and blocking the interface between the lead and the tissue. The ones we use the most these days look like this. They have an advanced little screw that can be advanced. You put it into position, advance the screw, it permanently bonds it there. The electrode is donut shaped going around it, and it also contains steroids to help reduce inflammation. So this is 99% of the leads that you'll see us use. So the pacemaker goes in the chest, get access to a vein one way or the other, but it's usually from within the same pocket. Lead travels through the subclavian vein into the SVC, and then either stops in the atrium or goes across the tricuspid valve into the right ventricle. It's important to realize that these leads do cross the tricuspid valve. In some cases, they can lay against one of the leaflets in a way that holds it open. And so tricuspid insufficiency is sometimes seen in these folks. If they get a pacemaker and suddenly have bad edema, it's very likely that they may have what we call tethering or propping up of one of the leaflets with the lead. When we put the leads in, let's see. What you can't see in this is the center of this lead is hollow. You can put a very long stylet, very stiff wire down the center of the lead, and that allows us to position it and move it very accurately and with precision. And at the end, once it's screwed into the tissue, we take that stylet out, and what's left behind is the lead is incredibly floppy and soft. So that usually prevents it from tethering the tricuspid valve open. You'll see us sometimes refer to unipolar or bipolar pacing. Unipolar pacing means that there's a connection here between the tip of the lead and the can. And the electrical signal goes between the electrical connection here and the can. So it goes through the chest wall. This makes for a very simple lead. These leads are metal and constantly bending with every heartbeat for the rest of the life. So metal, when it bends a lot, can fatigue and break. So these leads are simpler, a single conductor. The problem with this is that any electrical signal between the can and the heart is part of the circuit. So the muscles of the chest wall, what we call myopotentials, can be sensed and interfere with the operation of the device. It also takes more energy if you're developing an electrical signal that travels from here to here through the chest wall. So the battery life is reduced when you do unipolar pacing. The other option is bipolar pacing. There are two electrical connectors very close to the tip of the lead, and the electrical circuit is just going from one to the other. The amount of energy that's needed is very small, and there's a significantly reduced likelihood of any noise coming from the muscles of the chest wall or elsewhere, interfering with the ability of the pacemaker to see the electrical activity of the heart. Excuse me. So there's less energy needed from the battery, there's less noise can be picked up from the chest wall, but it's a more complex lead. It's got two metal conductors in it. Usually it's a single wire down the center, and then a braided wire going around it, like a coaxial cable, like the kind you have for your cable box at home. And that braided wire tends to be able to flex and move very easily. Positioning is more critical because the electrical circuit is confined to a very small area of the heart. If there's scar tissue, usually from a previous myocardial infarction, that won't work. So often we have to move these leads around the heart until we find a spot where the energy delivered in this very small space is reliably available to the rest of the heart. The leads can be positioned for the ventricular lead most commonly in the apex of the right ventricle, but we also run it up and down the septum. It can be placed up near the tricuspid valve, near the pulmonic valve in the outflow tract of the right ventricle. And the most recent leads can now be placed adjacent to the bundle of His, which I'll show in a moment why that's important. The atrial lead typically goes into the right atrial appendage. That anchors it very well, and the electrical activity is reliable there. We can't always put it there because the right atrial appendage is also where they place cannulas when they do cardiac surgery. They need a tube that empties venous blood and takes it to the heart-lung machine. It's a big, thick pipe, and they usually put it through the right atrial appendage. and then at the end they sew that over so there's no appendage left. So for post-cardiac surgery patients, we might have to go to either the septum or the free wall of the right atrium. Free wall of the right atrium often gives the best performance, but it's a very thin structure, and there are a lot of things on the other side of that wall, especially the phrenic nerve. And the electrical signal that's delivered to the heart can sometimes get through that very thin wall, so people get hiccups or twitching of the chest wall when you place the lead in the free wall of the right atrium. So if you see that on the floor, that's a big clue. The coronary sinus is a place to get access to the left ventricle, especially for bi-V pacers. And the lead position is always done under fluoroscopy. There's no such thing of doing this at the bedside. These are terrible x-rays, but this gives you an example. Here's a lead coming across, the tricuspid valve is right here. This lead comes across the tricuspid valve and ends right there. That's the most typical position. That's in the apex of the right ventricle. Here's an example of a lead that goes across the tricuspid valve and ends, the pulmonic valve is up here, so it ends up on the septum in the right ventricular outflow tract. And if you looked at it from the lateral view, there's the outflow tract and the apex is down here. Go back for a moment. The bundle of His is up here. The bundle of His is the piece of conducting tissue that connects the AV node to the right and left bundles. So it's a very short segment of conducting tissue that's connected to the right and left bundles. If you can pace into that, instead of pacing into the ventricular muscle, you actually pace into the conducting system. You keep both the right and left ventricles synchronized. It mimics normal conduction, and that's great. So this is a new trend trying to get His bundle pacing, and you'll see the leads placed up into the right ventricle. One of the things you haven't seen yet, because we haven't started doing this here as yet, but I think it's going to come very soon, is that in many cases we may put both leads in, and that's what this picture is. It shows a right ventricular lead and a lead in the His bundle, and that's because the lead in the His bundle doesn't always stay there. The target is a very, very precise piece of tissue, just a little bit of scar tissue or a little bit of movement, and may not work. If someone's dependent on the pacemaker for their rhythm, they'll need a backup. So we leave the right ventricular lead in as well. The problem with this is that you now have multiple wires going across the tricuspid valve, and that issue of tethering the valve open and giving someone tricuspid insufficiency is enhanced when you do it this way. In the future, we may have more reliable His bundle leads, and then not have to put multiple leads in there. In the cath lab, we measure the size of the P waves and R waves if they're there, and that's always reported to the floor. The impedance, which measures basically if it's an intact lead. Impedance is electrical resistance. I'm sure you all remember the physics course you took and all the electrical stuff that went along with current and voltage and resistance. But the idea is that if the resistance is extremely low, you probably have a broken lead. The two conductors are shorting out and touching each other, and there's no resistance to electrons. If the resistance is very high, it means you've probably broken one or the other of those two electrical conductors in the lead from motion all the time, or there's too much scar tissue where the lead touches the heart. In any event, very high resistance is no good because the amount of battery energy that it would take to keep working would deplete the battery very quickly. And a very low resistance or low impedance is no good because it's very unlikely that that electrical signal is actually getting to the heart. Probably coming partway down the lead to wherever the short is, and then going right back to the can and never pacing the heart. And then thresholds. When we deliver signal, does the heart beat? Top of the pacemaker, the wire goes into basically a plug, and then there's a little set screw that tightens it down and keeps it from moving. So one of the things that we always worry about, but fortunately rarely occurs, is that a patient comes to the floor and the leads are reversed. They seem to have only ventricular pacing, probably because the atrial lead is attached to the ventricle and the ventricular lead is attached to the atrium. That doesn't happen inside the heart. That's just attaching them to the wrong plug in the header. If the set screw is not screwed down tightly, you get very high impedance. That's the easiest kind of high impedance problem to fix, and that would be noticeable while the patient is still on the floor, before they go home. All of these folks get checked the next day, and if the next day check shows a high impedance, then that's a set screw problem. If it's not there then, it's not going to be a problem later on. That requires a trip back to the operating room, tighten it down, and you're good to go. Thank you.
There you go.
Did you buy me a car warranty?
I did.
Excellent. All right. I think you guys are all very familiar with this stuff, right? Bed rest, every operator is different. Some keep them bed rest for a day, some for an hour. There's no data to direct that. You do want to have them take it easy with the arm. Everyone sort of delivers the message, don't raise the arm above the shoulder. What you really want to do is don't raise the elbow above the shoulder, because range of motion below that doesn't move the clavicle. Any movement above that lifts the clavicle. The lead travels right onto the clavicle and can be pulled out of position. The difference in messaging is very important, because patients will go home and they may not think that they can brush their hair or brush their teeth, but they can, because their hands can go up above their shoulders without any difficulty. It's the elbow. So you don't want to have them reaching up this way. But the hands, don't leave them with the message, don't raise your arm, because the arm is too big. Elbow below the shoulder. 48 hours is the usual recommendation before it can get wet. Those wounds they'll seal up pretty quickly. You guys know wound care, left, right, and sideways. They should always be seen in either the physician's office or a device clinic within 7 to 10 days to look for early signs of infection.
Hey Jeff.
Yes.
Do you still do an X-ray post-op next morning or anything?
So we always do an X-ray the next day, and that's to serve as a baseline so that you know where the lead positions are when the patient goes home. So if they come in later and the lead is moved, you have something to compare it to. There are two ways into the vein. One way is to do a subclavian stick, where we advance a needle under the clavicle into the subclavian vein. And the pleural lining lays just under the clavicle. So as that needle passes, you can nick the pleura and you'll get a pneumothorax. So we always get a chest X-ray immediately after the procedure, not to look at the lead position, but to look at whether there's a pneumothorax. Some operators don't do subclavian sticks. Some of us will use what's called the cephalic vein, which isn't the subclavian vein. The cephalic vein is harder to get to. It's buried within the muscle, and there's a little groove of fat. We can find it and directly access the vein without having to use a needle. The advantage of that approach is that since you don't use anything sharp near the pleural space, there's no way you can get a pneumothorax. So you will see some inconsistency on the X-ray that's ordered right after the procedure. Some patients it won't be ordered, some patients it will, and that's always a result of whether it was a subclavian or a cephalic vein access. The day after X-ray is for baseline lead placement. This is the coding system that I think you guys are all familiar with, BVI, DDD, that kind of stuff. Do you need me to go over that, or you know that? I'll go over it. First letter is which chamber is paced. So a VVI pacemaker, the ventricle is the chamber paced. A DDD pacemaker, both the atrium and the ventricle, D stands for dual, are paced. So the first one's the chamber paced. Second is the chamber that's sensed. There was a time 30, 40 years ago that the electronics were much simpler, and it might pace in both the atrium and the ventricle, but only sense on one of those channels. These days, all pacemakers can sense on all channels, so this probably doesn't need to be there anymore. It's going to be dual. The third is the response to pacing. So that's either inhibited, triggered, or both. Inhibited means it's watching, and every time a native beat shows up, it inhibits the pacemaker. So it doesn't have to do anything. And at the end of a certain amount of time, like if it's set to 60 beats per minute, after 1 second, if it hasn't seen a beat, it will provide one. But every time that there's a normal beat from the patient, it inhibits the pacemaker, starts counting again. Triggered is the opposite. If there's a certain signal received by the pacemaker, it will tell it to provide a paced beat. So for instance, if it's a dual chamber pacemaker and it sees a P wave, that'll trigger an R wave. It'll trigger a ventricular pacing spike a short time later. So it can be triggered. If it sees a P wave, it'll trigger ventricular pacing, and it can be inhibited. If it sees electrical activity that comes natively from the heart, it'll know it doesn't have to provide that. The next letter is just R. It says 0 or R, but we never put the 0 in there. R means rate modulation or rate response. So most pacemakers nowadays have the ability to make a guess as to how active you are. They use 2 different ways of doing that. Some pacemakers have a little motion sensor in there, and the more it's moving around, the more active it thinks you are. And that's important because we're going to tell it to pace somebody, let's say at 60 beats per minute, when they're at rest. But if they're more active, we may want them to go 70, 80, or 90 beats per minute to help keep up with the demands of being active. So that's rate response. The motion sensor is one. The other way it has is of measuring activity is called thoracic impedance. So between the can and the tip of the ventricular lead, it can measure the electrical resistance. The closer they are to each other, the less resistance. The further away they are, the more resistance. So this can be very useful because the harder you breathe, the faster that signal will travel from low to high and high to low. The slower you're breathing, the slower that'll be. So the thoracic impedance way of doing things is very nice because it doesn't depend upon motion, but it's always playing catch up. You don't start breathing hard until after you're already doing stuff. And so the ability of the pacemaker to know that you're becoming active isn't very good. The motion sensors are very good at picking up motion. As soon as you start being active, it can start raising the heart rate, but it gets fooled by a lot of things. For instance, there's a lot more motion to the pacemaker can when you're walking down a flight of stairs than up, because when you walk down, there's a certain amount of bouncing that goes on. When you go up, it tends to be a very smooth motion. So it's not a perfect system either. There are some manufacturers that have tried to put both of them into the same can. Those details are probably not that important for you guys, except to know that if there is an R in the 4th position, that would be the reason why if you know that somebody was programmed to a base rate of 60 beats per minute, and they're pacing at 75, and you say, what? They're at 60, why are they pacing at 75? It's probably because rate response is on and they're taking a walk in the hallway or something that has raised the pacemaker's base rate. The 5th position, you're not going to see it very often, but with CRT, with bi-V pacers, there can be more than one lead in a given chamber, usually in the ventricle, one in the right ventricle, one in the left ventricle, or both KISS and apical right ventricle, as we talked about before. So if there's multi-site pacing, there'll be an indication over here. So most of the time you'll see what's called DDD pacing. It paces in both chambers, it senses in both chambers, and has the ability to both be triggered and inhibited. The second most common one you'll see is DDDR. Same thing as a DDD pacemaker, and we've turned on the ability to be sensitive and aware to how active you are. I think it's extremely unlikely you'll see any of the other configurations. Oh, excuse me, and VVI. That would be someone who has permanent atrial fibrillation. So they only have a ventricular lead-in. And it would be pacing and sensing in the ventricle, V, and then I for inhibited. So the mode we just talked about can be single or dual chamber, the lead configuration, unipolar and bipolar, we mentioned. These are the basic parameters that you'll see when they come out of the cath lab. The base rate, that's the lowest rate the heart's allowed to get to, most of the time. There are occasional situations where it can get lower than the base rate, and we'll talk about that in a minute. There's an upper tracking rate. If we turn on rate response, we'll tell it, all right, you can go above the base rate up to 110 or up to 120, but there's gonna be a maximum rate above which the pacemaker won't go. Similarly, if it's in a patient who has their own sinus rhythm, it's gonna watch the atrial rhythm and provide a ventricular beat for every P wave that it sees, up to a certain maximum tracking rate. So if the patient suddenly develops a heart rate of 150 in the atrium, as you would see with flutter, it's not going to try to pace at 150. It'll pace as high as the upper tracking rate. Typically we set that around 120 for most people. If someone's old and frail, we may go lower than that, and if someone's young and athletic, we may go higher. Rate adaptive pacing we talked about a moment ago. We can program the AV delay. Every time it sees a P wave, there's a fixed amount of time before it expects to see a QRS, or else it will provide one. The AV delay is how long it waits after providing an atrial event before it paces the ventricle. That can be fixed. Typically, we might say it's like a normal PR interval, 120 milliseconds, something like that. But if someone's heart rate is going up with activity, in response to the rate sensor, it now has the ability to be what we call rate adaptive, meaning the faster the heart rate, the shorter the PR interval. And that's what happens physiologically. So when you see a fixed PR interval in someone who has a pacemaker, and it's different from one day to the next, look and see if their heart rate is higher from one day to the next. Because in most cases, we are shortening the PR interval as the heart rate goes up. And then there are a lot of smarts and artificial intelligence that are being put in these devices to help it make programming choices on its own. This is well beyond what we're going to talk about today, but the idea of refractory periods is critical to how the pacemaker responds. Every time there's an atrial event, whether it's sensing a P wave or pacing the atrium, and every time there's a ventricular event, either sensing an OR wave or pacing the ventricle, both the atrial and ventricular circuits are going to go deaf for a short period of time, so that they don't get fooled by the signals that happen, the noises and electrical signals that happen right around the time of pacing. The most common situation would be when the ventricle fires, some of that signal is going to make it back to the atrium. And if the pacemaker thought that that was another P wave, it would then tell the ventricle, oh, you got a fire already. And then it sees it again. So that's called the post-ventricular atrial refractory period, or PVAR. And there are many different refractory periods that can be programmed, and it gets quite complicated. But the PVARP is the big one because that's what allows the atrium to be immune to normal ventricular pacing, but still be able to know what are legitimate P waves. There's something called auto threshold, and I'm gonna have to come back in a month to go through some of these because there's not enough time today. Auto threshold is very important to know about on the floor. That is a programming option that allows the pacemaker to change how much energy it's using to capture the ventricle in an effort to save battery life. What it means is that 3 times a day, you're gonna see what looks like inappropriate pacing. 5, 10, 20 beats of pacing where there should be no reason for pacing. And that's because the device is intentionally pacing, changing the energies and taking measurements so that it can reset the pacing threshold. It's a normal function when auto threshold is turned on. But if you're not expecting it and somebody's just sitting up there on the floor with a heart rate of 80 and suddenly they're paced at 100 for 8, 10 beats, that's what's going on. There's PMT protection, which we'll talk about. Automatic mode switching is an algorithm that says if the heart rate is going very high or behaving in a way that we don't expect, the pacemaker has the authority to reprogram the mode that it's in. The most common example would be somebody is in a dual chamber mode. They're pacing their atrium and their ventricle, and they go into atrial fibrillation or an SVT where the atrial rate is very high. It'll recognize that. It'll switch its mode to being a ventricular only pacemaker, but it'll continue to monitor the atrium. And if the fibrillation goes away, it'll reprogram itself back to a dual chamber mode. It's called automatic mode switching. We'll show some examples. And then there's something called noise reversion, which I'll show some examples. Very common question about magnets. When the magnet is applied, it forces the pacemaker into asynchronous pacing. VOO. In other words, it paces the ventricle. It's not sensing anything, and it's not triggering or being inhibited. So all it's doing is pacing. It is completely independent of what rhythm the patient is in. So if you put a magnet on a patient, you'll get asynchronous pacing. And if it's a dual chamber pacemaker, it'll be DOO. If it's a ventricular, it'd just be VOO. This doesn't exist anymore. That's left over from a very long time ago. The other thing that is less well known about applying a battery is that when you put applying a magnet, is that when you put the magnet on a pacemaker, the rate that it paces at is a rate that cannot be programmed in. We can tell a pacemaker to go at 60, 65, 70, 75. We can't tell it to go at 62 and a half or something in between those fives. But when you apply a magnet, it goes at a rate that can't be programmed in, typically like 87 beats per minute. And that's how you know if you see a strip that it was either magnet application or ventricular pacing. That non-programmable rate changes based on the condition of the battery. So that's, without using a programmer, that's one of the ways that we can do a quick and easy test to see if someone's battery is running down. When it gets down about 80%, hasn't stopped working yet, the rate at which the pacemaker paces when a magnet's applied changes to an alert rate, a rate that you can look up from the manufacturer, and it says this is a low battery state. And then there's this pacemaker-mediated tachycardia, which we'll talk about. Magnets it's the quick and easy way to stop a pacemaker-mediated tachycardia. You just apply the magnet, count to 3, take it off, and the tachycardia will be gone. And we'll talk about that in a moment. That top one, you don't have to worry about. The rate when a magnet's applied depends upon the remaining life in the battery. We just talked about that. For the St. Jude or Abbott devices, which are about 95% of what we put in here, the normal pacemaker rate when you apply a magnet is 98.6 beats per minute. You can't program that in. And when the battery runs down, it goes to 86.3. So if you see those kinds of rates, you know that either a magnet's been applied or the battery's running down. And something happened on the slide. There's actually an electrogram up here. But asynchronous pacing, can you guys see that blue thing up there or not? Not really. What it shows is that there's a spike here that captures the ventricle. You know what the paced beats look like, the wide, strange beats. Then there's a native beat and a pacemaker spike, and a native beat and a captured ventricular event. Basically what's happening is that there's a mixture of paced and non-paced beats here, and that's asynchronous pacing. So if the spike falls, for instance here, when the ventricle is refractory, it does nothing. If it falls here, when the ventricle can be paced, then you get ventricular pacing. And it is completely regular, and it is completely independent of whatever heartbeats are normally there. So it's asynchronous, it's not sensing anything. And it's intermittently capturing just because of the normal behavior of the heart to be refractory after each beat. When someone has an ICD instead of a magnet, when someone has an ICD instead of a pacemaker, and you apply the magnet, it doesn't do anything that we just talked about. The only thing a magnet does on an ICD is turn off the ability to shock for VT or VI. So if someone's having inappropriate shocks, that sort of thing, you'll see us put a magnet on or even tape a magnet in place, and it's not having any effect on the programmed pacing characteristics the way it would for a pacemaker. The potential complications when we put these things in, the stuff you always see us talking about. The leads, especially if someone's old and frail, and the right ventricle is very thin, or they've had a right ventricular infarct, placing those leads can cause perforations, and they come back to the floor, get hypotensive, sweaty, tachycardic. You have to worry about tamponade. Same thing with atrial leads that are placed anywhere other than the appendage. And then we talked a little bit about pneumothorax. If they come back and they're short of breath, tracheal deviation, no breath sounds on one side, that's an emergency. They have a pneumo. Easy to check with a chest x-ray, very easy to treat with a chest tube. So those are the two big bad things that we worry about when they first come back from the lab to the floor. So that's why we want close monitoring at the beginning. Hypotension, tachycardia, chest pain, these are medical emergencies because they could be either a pneumo or tamponade. And an echo for any drop in blood pressure is mandatory. Obviously, these are the things you worry about the next day, is bleeding and infection, a swollen pocket, a discolored pocket, drainage out of the wound margin, tenderness, cellulitic changes are all a concern. Hematomas, they'll resorb. The one thing we worry about with the hematoma is it can put tension on the suture line, parting the skin and allowing a route of access for infection. Compression is the way to treat these as long as someone's not too uncomfortable with that. We worry a lot when there's an immunocompromised host and bleeding because of the heightened risk of infection. Within the first day or two, this is another thing we worry about. You see there's 2 leads coming down here, 2 leads going across the tricuspid valve and into the right ventricle. That's because there was an atrial lead here and that screw didn't get a good bite into the muscle. And with the repetitive heartbeats and motion overnight, it released from the tissue, gravity lets it fall across the tricuspid valve, the flow of blood takes it across the tricuspid valve, and now you have 2 wires in the ventricle. Late complications after they go home will sometimes result in them coming back to the hospital. This is rare, but when it happens, it's quite severe. It's a pocket neuralgia. Some patients sort of
Code sepsis,
random
ED20,
event
now. Code sepsis,
where a nerve ending is
ED20,
correctly
now. Code sepsis, ED20,
stimulated by either
now.
a wire or the device, and it's a neuralgia, and it's profoundly painful. These patients often need their system explanted, the pocket changed in shape and size, and the system placed back in. Infection can cause pain in the pocket. Usually you're gonna see a lot more than just someone complaining of pain, because this is superficial enough that the signs of infection will be there. There are certain organisms that can be very, very insidious and take a long time to show up and don't cause the typical redness and cellular changes. Erosion is always a concern. I'll show a picture in a second. Especially in smaller and more frail folks, there is tension over the edges of the device. That tension decreases capillary blood flow. That area becomes more vulnerable to erosion of hardware through the skin. Migration can happen, especially in women, if it's not placed really on the muscle, but into the fat that becomes the upper portion of the breast. That is not a pocket that will ever encapsulate, and the device can migrate down the chest wall or down into the breast. Problem with that is it puts tension on the leads, and that can lead to lead failure. Twiddler syndrome is when, and it's a real thing, people sit there and they flip the device over in their pocket. It's a habit. And this is what it looks like when we reoperate. I mean, they can twist that thing up pretty good. And it's just like a rubber band, you know, the more you twist it, the shorter it gets. And this can actually pull the leads out of the heart when they do that. And then we worry about thrombosis of the vein. The lead is traveling through the subclavian vein into the heart and can lead to occlusion of the vein. So if someone has a pacemaker and they come back into the hospital and that arm is edematous, we worry about venous thrombosis. They get anticoagulated. Rarely surgery would be necessary. This patient came in 2 years after the device was implanted. This is an example of tension causing erosion because of compromise of capillary blood flow. It's a very slow and insidious process. The leads can break, typically where they make the turn to go under the clavicle into the subclavian vein. That lead is now rubbing against the bone, and in a saw-like or sandpaper-like fashion, it can erode through the outer insulation. There's that coaxial cable conductor under the insulation. So if the clavicle erodes through the insulation, that conductor gets exposed. That changes the impedance and the ability of the system to function. In that case, we have the ability to reprogram the device to unipolar, and it doesn't use that conductor anymore, it just uses the wire that's going straight down the middle. And often you can salvage the system that way. The wire is anchored, and if it's tied down too tight, it can erode through the insulation. Angulation of the lead, usually from twiddlers, or changes in some people between the position when they're laying down to when they stand up, especially large-breasted women where the breast may pull the pocket down. It can cause a sharp bend in the lead, and that becomes a fracture point. And the external conductor gain. So we try to do dual chamber pacing whenever we can, and that's because it mimics normal physiology the best. It keeps atrial and ventricular contractions coordinated, and it keeps the timing as close as you can to normal physiology so that the atrial contraction delivers blood to the ventricle, stretching the muscle a little bit. You remember Starling's curve, and preload, you know, if you stretch the ventricle, it's gonna be able to squeeze more strongly. So you're trying to capitalize on that. So normal physiology includes atrial contraction followed in an appropriate period of time by ventricular contraction. It's synchronization of the atrium and the ventricle. When you lose that, some people can develop symptoms. And that's why we put a dual chamber system in, is to avoid those symptoms. The most prevailing concepts about why those symptoms develop when you just pace the ventricle is pacemaker syndrome, which is the phenomenon of the atria contracting when the tricuspid and mitral valve are closed. Because if you're just pacing the ventricle, every time the ventricle is paced, those valves will close. But the atrium doesn't know that. And so if it tries to pump against a closed valve, you're gonna get throbbing in the neck or wherever the back pressure goes. That's called pacemaker syndrome. So putting a dual chamber pacemaker in takes care of that because the ventricular contractions will always be coordinated with the atrial signal. Sensing it's a simple concept, but it's often misunderstood. So the P waves have a certain amplitude in millivolts. The R waves have a certain amplitude in millivolts. And we adjust what's called the sensitivity, and some people feel like the idea of sensitivity works backwards, but it doesn't. The higher you make the number, the less sensitive it is. So what this number means, if you set the sensitivity at 5 millivolts, it means it's only going to see things that are higher than 5 millivolts. If you set the signal at 2 millivolts, you'll see things that are higher than 2 millivolts. So as you make the number go down, you see more and more of the signal. Okay. If you want to make the device more sensitive, you set the sensitivity to a lower number. So for R waves that might be 7 millivolts or R waves that might be 3 millivolts, if you set the threshold at 4, you're going to see the pacemaker will see this R wave and it will not see this R wave. If you set it at 2, it'll see both. The lower you set it though, the more it becomes vulnerable to things like the electrical signals from the chest wall muscles or other sources of noise. So you want to set the threshold high enough to not let the device be tricked by seeing noise, but low enough that it will reliably see every R wave or every P wave that comes by. And that's why when we implant these things, when we implant the leads, we always want the R waves and the P waves to be large enough that we can set a reasonable sensitivity so that the device can be reliable and not vulnerable to noise. We talked about what inhibition means. So this is an example of atrial sensing and inhibition. Here's a P wave, the device sees it, so it's inhibited, provides no pacemaker spike. In this case, P wave, it's seen by the device, and there's no pacing. If we had calipers, this interval is shorter than this interval. From here to here is the maximum amount of time the device is allowed to go without seeing electrical activity. So when that amount of time passes, it provides an atrial signal. There's a new P wave, which is stimulated by the pacemaker. You can see that this P wave is going down, this one is going up. That's just this example, but what is always true is that the P waves will look different. Native P waves will look different than paced P waves, but it's not always one's up and one's down. So for these 3 beats, no P waves were seen, so the device is providing pacing, and then it is able to see the heart's own P waves again, which inhibits the pacemaker. It doesn't have to do anything unless one is missing. That's ventricular sensing and inhibition. This is the same thing. Here are a bunch of paced atrial beats. There's a programmed AV delay, and as long as there's a QRS within that time frame, it inhibits the pacemaker. So you see pacing of the atrium, but no pacing of the ventricles. This is just the pacing rate or the pacing interval. It's expressed, you'll see us talking about it in terms of both beats per minute or milliseconds. And converting between the two is actually much simpler than you would think. The number is 60,000. So if you want to convert from beats per minute to milliseconds, or from milliseconds to beats per minute, just take the one that you know and divide it into 60,000. So for instance, if the device is set to 60 beats per minute, 60,000 divided by 60 is 1,000, so the pacing interval is 1,000 milliseconds. If we're telling you that the device is programmed for an RR interval of 1,000 milliseconds, you want to know how many beats per minute it is. Again, it's 60,000 divided by that 1,000, and that'll give you 60. So you don't have to remember which way you're converting. Whichever way, whichever number you have, you divide 60,000 by it and you get the other number. And just a reminder, each big box is 200 milliseconds. Each of the tiny little boxes is 40 milliseconds. And 5 whole boxes is 1,000 milliseconds or a second. Every time, in this case we're looking at the atrial channel, every time it sees a P wave, it starts an alarm clock. And that's what you see here, the pacing interval, the number of milliseconds necessary to achieve that heart rate. At the end of that pacing interval, one of two things will happen. Either it will have seen another P wave or it won't. And each of these yellow boxes has to do with what happens starting at each P wave. So if from this P wave to this P wave, the alarm clock hasn't timed out, the device is inhibited. In this example, from this P wave to the end of the pacing interval, let's do it this way, it doesn't see anything, so it provides a pacing spike. Same clock starts. If it hasn't seen anything, it provides a spike. And that continues until a P wave is seen before the pacing interval ends. This is the same thing in the ventricle. There's a clock for timing from the R wave to the R wave. If it doesn't see one, it provides a spike. The complex looks very different, which we'll talk about in a moment. And this just shows that it's inhibited whenever it sees a native R wave. Capture, you know what that is. So this shows one-to-one capture of the atrium. In this case, the ventricles are not paced. There are situations where it may not capture every beat. It may capture every other or every third. That's very rarely seen now because the devices are very smart and prevent that. Typically that only happens at very high heart rates. It has to do with those blanking or refractory periods of the device. Paced beats don't look like normal QRS complexes. They're much wider because the signal is not being delivered to all the muscle through the very fast conducting fibers of the conducting system. It's just a reminder, there's an AV node here, there's the bundle of His. Bundle of His then divides into the right bundle and the left bundle, and at the moment a signal gets through the AV node, it is very quickly delivered all the way to the apex and along the lateral walls of the heart, and the whole heart contracts at the same time. Because the whole heart contracts at the same time, the QRS is narrow. If you were to pace into the muscle, it's not going through these specialized conducting fibers. It travels much more slowly through the muscle. So it would travel as a wave, let's say from here out this way and up this way. That takes more time, the QRS gets wider. Remember, wide or narrow is just a measure of time. The wider something is, the longer it's taking to occur. If somebody has a break in the left bundle, you get a left bundle branch block. If somebody has a pacing lead down here in the right ventricle is stimulated first. That's exactly the same as the left bundle branch block. Because in the left bundle branch block, the signal does get to the right ventricle, but not to the left. So pace beats and left bundle branch block beats look the same. Let me go back for a second. If we were able to pace right into this little piece of the His bundle, you can see it would be a very narrow complex. That's what we had talked about before. You'll see us talk about fusion beats. That's a common source of confusion on the floor. This is atrial fusion, it's harder to say. Here's ventricular fusion beats. Here's a normal paced beat. It's wide, it has the same shape and size as the left bundle branch block beat. This beat also has a pacing spike, but it looks different than a normal paced beat. It's kind of narrower. It's not as narrow as a normal beat. It's not as wide as a paced beat, but it's in between. And what's happening here is that the pacemaker is delivering a signal, but the patient was going to have a QRS anyway. So it's a combination of the two. And I'll show you in a moment why that occurs. And then you can get even more confusing is this kind of beat. It looks exactly the same as the normal non-paced beats, but it has a pacer spike. And that's called a pseudo-fusion beat. So there's paced beats, normal beats, fusion beats, and pseudo-fusion beats. Skip over that. Here's the explanation. So when the signal comes down from the top of the heart, it goes through the AV node, travels down those conducting system fibers, right and left bundle, and it gets down to the apex, and then it starts spreading up from the apex through the muscle. That takes time. During that time, the pacemaker doesn't know that a R wave has been generated because the signal's still traveling down the septum, but it hasn't gotten to the tip of the lead yet. So if during that period of time, the pacemaker decides, I haven't seen an R wave yet, I should provide one, it delivers a pacing spike. And the signal that's coming down the septum, that's intrinsically conductive, and the signal that's coming down from the pacemaker will both depolarize the muscles from two different positions. That's a fusion beat. It's the fusing of both beats. A pseudo-fusion beat is when the circumstances have to be just right, but when the intrinsic signal is coming down, it hasn't quite reached the pacemaker yet. And the pacemaker fires a beat, but it's just pacing tissue that's already been depolarized. So it has no effect whatsoever. So fusion beats still pace the ventricle, but the ventricle was firing anyway. A pseudo-fusion beat is a matter of just random timing. It's completely harmless. And it doesn't mean that there's a failure to sense. And that's why I'm talking about this. Because often when people see this kind of thing, they're thinking, oh, something's gotta be wrong here. There's a QRS, but there's also a pacer spike. There's no danger in any pacing spike that occurs within the QRS complex. It cannot trigger any arrhythmias. It's not like R on T, where you'd worry about pacing into the refractory period. It's completely harmless. So these are the electrograms you're most commonly going to see. This is, and we tend to use the 4 letters A, V, P, and R. So A and V talk about pacing, means either atrial pacing or ventricular pacing. And P and R stand for the intrinsic electrical activity, P waves and R waves. So when we talk about, well, we'll go through this. So this would be AV pacing. There's a pacing spike, P wave, pacing spike, QRS. This would be PR, excuse me, PV pacing. The P waves are intrinsic, but we pace the ventricle. So it's not PR, because that would mean that it sees both, it's PV. This would be, anyone want to say? This would be AR, pacing the atrium, but the R wave is native. If you're pacing the ventricle, it would be AV, but this would be AR. This is the terminology you'll see in the charts. So this gives examples of all of them. This is AV, this is PV, this one is PR, and this one will be PV. Oh, LR. So that's atrial pacing, intrinsic R wave, intrinsic P wave, intrinsic R wave, intrinsic P wave, paced ventricle, and paced atrium, and paced ventricle. We talk a little bit about the AV delay. You guys are used to looking at that. With pacing, there's some differences between the AV interval and the PR interval, having to do with the circuitry. So the PR interval has to do with native conduction, and the AV delay is what's programmed into the device, and they can be different. The programming issues have to do with trying to mimic the normal AV synchronization and optimizing cardiac output by delivering the best timing so that the ventricular stretch that occurs after atrial contraction provides the best preload so that the ventricular output is higher. The other thing that we do is we try to stretch out the PV delay as much as possible without compromising normal hemodynamics, because if we can encourage intrinsic conduction, you get a narrower QRS, better cardiac output, and better cardiac performance. So we'll often try to set the PV delay, so the delay before the ventricle is paced, when it sees a native P wave. We try to stretch that out as long as possible. Some pacemakers, actually most of the pacemakers we're putting in nowadays, will constantly make adjustments themselves to stretch out the PR interval to allow for intrinsic conduction. So what you'll often see is that one day you'll see a PV delay that's short, and the next day it may be longer. It's not that the pacemaker is failing to conduct through the way it was programmed, but just that the automatic ability to reprogram that PV delay is in use. The AV delay has to do with what happens when you're pacing. There, we don't necessarily want it long. If you're going to pace from the A to the V, keep it short, make it physiologically the most effective it can be. So the PV delay will often be set long, and the AV delay will be kept short. This is rate response. When the atrial rate rate response for the AV delay, we'll shorten that AV delay as the heart rate goes up to mimic normal physiology. And this is just an example of how it's done. When the heart rate gets up to 90, the device will be told to add a certain number or subtract a certain number of milliseconds from the programmed AV delay. And we can change that. And we have, what you'll typically see on the floor is programmed to low, medium, or high. A young active person, we want it high. As soon as you get active, we want it to change. An old, frail person, we might want it to be much more gentle. The bundle of His and the AV node will conduct the signal in both directions, from the ventricle to the atrium and from the atrium to the ventricle. It's not, we always think of it as conducting from the atrium to the ventricle, but wherever there's a signal first, it will carry the signal the other way. So one of the big problems we have with pacemakers is the tendency to, when something happens in the ventricle, for it to travel the wrong way and arrive in the atrium, so-called VA conduction. So retrograde VA conduction. The most common trigger for it is a PVC. You have a PVC, it goes back through the AV node, and it can depolarize the atrium. And it can also occur if someone has abnormal tissue to connect the atrium from the ventricle, and Wolff-Parkinson White is the most common form of that. The second most common form of it is a pacemaker, because a pacemaker connects the atrium to the ventricle and can act like a bypass tract. So this is what we call pacemaker-mediated tachycardia. A PVC is the most common cause. A PVC will cause a signal that travels backwards through the AV node, arrives in the atrium. Pacemaker has a lead in the atrium and says, I just saw a P wave. I'm going to wait the programmed AV delay and pace the ventricle. And then you set up a circuit where the signal arose from the ventricle, went backwards. It was sensed as a P wave. Pacemaker quickly tells the ventricle to fire again. That signal continues to go backwards, tells the pacemaker to fire, and it goes very rapidly. And this is what you'll typically see. Some sort of normal rhythm, whether it's paced or intrinsic, a P wave. That P wave travels the wrong way, and it sets up this circuit. Typically, this will occur at the upper tracking rate. So if the pacemaker is programmed to go from 60 to 120, you'll see this at 120. It doesn't always be at exactly that rate, but that's a very reliable, sort of quick and dirty way to say, could this be a pacemaker-mediated tachycardia? The trick is, the trick for stopping this, of course, is to just prevent one beat from traveling backwards through the atrium, or prevent the pacemaker from tracking that. So you can apply a magnet. Magnet makes it asynchronous. It's not going to care what the heart is doing. If it's programmed at 60 beats per minute or at 90 beats per minute, you put the magnet on, count to 3, take it off, and that circuit won't exist anymore. The device has an ability to stop this on its own. It changes that PVAR. Every time it sees a PVC, that ability to make the atrial circuit refractory will be extended. So every time it sees a PVC, meaning a ventricular signal with no P wave before it, it'll make that refractory period longer, and that should prevent a PMD from occurring. Yes?
Is that something you put an order in for, is by the magnet?
No, for the magnet?
Yeah.
If you see a PMT, the patient will either be stable or not be stable. So some folks at 120 may get ischemic, they may get chest pain, shortness of breath. In that case, you're obviously going to be calling, the hospitalist or us, depending upon the time of day. But you would probably want to just go grab a magnet and have it in the room. All right. If somebody's very unstable, I have no idea what the nursing protocols are here, but you're never going to hurt anyone by putting a magnet on. You can't hurt anyone by putting a magnet on. So I don't want to quote hospital policy, but if it's something that cannot, under any circumstances, hurt somebody, it would make sense that if somebody was unstable from the tachycardia, you could do it. It's different than giving them a medication or something like that. What is the rule here? Do you know?
I missed the beginning part of the question.
Oh, if you see what looks like a pacemaker-mediated tachycardia and someone's unstable, can the nurse just apply a magnet, or do they need an order? You can't ever cause any harm.
I mean, we can look at that and make that part of the protocol. It seems if that's what you'd recommend, then I certainly think it's within.
Yeah, I mean, it's different than giving adenosine or something
Yeah.
like that. I mean, this
Yeah.
is,
Yeah.
it's gonna work or it's not gonna work, but it can't hurt.
Right. I'll pull it up now and see if we have anything.
All right.
You guys would be comfortable doing that? I mean, that makes sense, yeah?
let's see. Um, This gets into the timing diagram. So this is an example here. Normally, after the ventricle fires, there's a period of time during which the atrial circuit can't respond to anything. When it sees a PVC, that is extended. So even though the signal got up to the atrium, going backwards through the AV node, it can't trigger a pacemaker-mediated tachycardia. This is called the PVC option on a pacemaker. If it's turned on, it should prevent a pacemaker-mediated tachycardia. If it doesn't, you can apply a magnet and terminate it. There's also something in the device called a PMT option, pacemaker-mediated tachycardia option. It has the ability to recognize when there are 10 consecutive beats at or above the upper tracking limit. And then it can make a decision about which is occurring first, the atrial signal or the ventricular signal. If it looks like the ventricular signal is followed by the atrial signal, it'll interrupt pacing for a very short period of time, and that should break the cycle. From your standpoint, one of the things, there's that sheet of paper that comes out after every pacemaker implant. On the first sheet, it will always say whether the PVC option is on or the PMT option is on. And you'll be able to look at that now that you know what they're called and just see if they're on or if they're off. If the patient's having episodes of tachycardia, and you look at that piece of paper and all these options are turned off, that would be a call to us to say, I think this patient needs attention. This is an example of how the device will terminate the rhythm itself. This is a pacemaker-mediated tachycardia. The R wave is actually preceding the P wave. It's been sustained. The device recognizes it after 10 beats. It extends that refractory period. This P wave can no longer get back up through the system, and a normal rhythm is restored. And it should do that all on its own. For manual termination of a pacemaker-mediated tachycardia, you can either apply a magnet and then remove it, or use the programmer, which you call us to do. Is Merlin on demand on the floors or only in the ER?
Is what?
Merlin on demand? Okay. Merlin on demand, we should think about getting it on the floor as well.
Anybody know what that is? Oh, okay.
So Merlin on demand is a little box. It's completely automated. You hold it over the pacemaker. It will diagnose what's going on, or actually gathers information necessary. It's sent to a 24/7 team of pacemaker physicians and technicians at Abbott at the St. Jude, and a faxed report comes back in, I think, 3 to 5 minutes, diagnosing what's going on with the pacemaker. And you literally just bring it over and hold it on. It's got its own cell phone. You don't have to connect it to anything. You don't have to link it to a computer. We have it in the ER, and I think we have it in the recovery room. So it can literally just walk in, hold it, and wait for the phone to ring. And usually be one of us calling back to say, I'm on my way in, or could you put a magnet on, or how's the patient feeling, but we'll know what's going on.
PACU recovery or cath lab recovery?
PACU recovery.
PACU recovery?
Yep.
Okay.
Noise, and I'll stop after this one for today. So noise is a big issue. The most common examples of noise or electrical signals that the pacemaker, what I mean by noise is electrical signals that the pacemaker can't be sure, is that coming from the patient's heart or not? The best example would be the use of cautery in the operating room. If somebody is dependent upon their pacemaker to provide their rhythm and somebody applies cautery, that's an alternating electrical signal the pacemaker may think those are our waves. It'll be inhibited. It doesn't have to provide a pulse, and the patient is asystolic as long as the cautery is applied. Some patients like to work on their own lawnmowers or use an arc welder at home, or are antique car enthusiasts and they put their arm under the hood where the ignition system is generating those sparks and the spark plug coils. All these things the pacemaker will think are R waves. That's noise. If the patient is pacemaker dependent, they'll pass out from that. Mild potentials, especially with unipolar pacing, that's biological electrical activity from the muscles of the chest wall. No different than the muscle of the heart, generates the same kind of electrical signal. And lead fractures can generate a lot of noise. If the insulation is worn through and the underlying electrical conductor is in contact with any other tissues, pacemaker doesn't know that those signals aren't coming from the heart. So, I mentioned at the beginning that sensing is based on rate, slew rate, and frequency. So a lot of noise will either have slew rates, the rate at which the signal changes, or frequencies, how often it's occurring, that are outside the range that could be considered a normal cardiac signal. And the device will ignore it as noise, but it doesn't always, that's not always reliable. So the pacemaker has the ability to recognize noise and make changes. And the change that it makes, and the reason I'm talking about this is you'll see it on the floor, is when you see a pacemaker go from paced rhythm like this to AV asynchronous pacing for what seems like no reason, it's because the device is sensing noise. Its fallback, its safest position if it's unsure, is to provide asynchronous dual chamber pacing. So when you see somebody go from, in this case it would be an AR rhythm, pacing in the atrium, normal conduction to the ventricle, so it's an AR rhythm to an AV rhythm at pretty much the same rate. It's because there's noise coming in on the signal. It doesn't mean that this pacemaker is broken. So when you see that kind of a change with no other good reason, you can assume that there's noise. That's what I was going to